This is LiveWell Talk on new Clinician Spotlight. I'm Dr. Dustin Arnold, Chief Medical Officer at UnityPoint Health, St. Luke's Hospital. Today's episode is another installment in a series of the podcast where we sit down with new clinicians at UnityPoint Health and to get to know them as a clinician and as a person. Today's guest is Michele Tangeman, a nurse practitioner at St. Luke's Heart Care Clinic. Michele, welcome to the podcast.
Thank you.
How come you only have one L in your name?
Oh, I don't know. That would be my mom.
So there's no story behind that?
There's no story behind it, but I'm named Michele because my dad is Michael.
Okay.
So I'm kind of like named after him in a way.
Okay, so they just put
I don't know if that changes the spelling or not, but
maybe. Maybe.
It makes it difficult for everybody to spell it correctly all these years.
Everybody puts an L in it, doesn't
everybody puts an L in it, that's right.
Well, tell us a little bit about yourself. I know we were talking prior to the podcast that you were in the ICU and the MICU, or the critical care unit here at St. Luke's, but tell us what brought you to UnityPoint Health. You started here as a nurse. When?
I actually started here as a tech right when I was in nursing school. So I started in 2011 is when I started as a tech on the telemetry units. The reason that I got a job here is because my mom was actually a cardiac rehab nurse here for about 40 years. So I think when they moved to town, they originally came from Texas really, but when she moved to town, she started a job here at St. Luke's and stayed basically the entire time.
Who's your mom?
Mary Tangeman.
Oh, I didn't know that.
Yeah.
I didn't put two and two together.
Yeah.
Yeah, she's 40 some odd years. Yeah.
Yeah. So, I don't know, legacy nursing, I guess is what it would be. So I originally started.
Nobody else wanted you.
Yeah.
And they felt
that's
sorry for you.
Yes, my mom had to.
And everybody liked
my mom
your mom.
had to get me in the door is what it was.
That's okay. That's okay.
So I started as a tech on the telemetry unit, and then when I graduated from nursing school...
She just probably didn't want you living in the basement forever.
That's what it was.
That's why she's like, okay, let's get her a job.
Yeah.
Yeah.
Or at least get me to pay rent.
Completely empathize with that.
Yep.
So go ahead.
Oh, that's okay. So I was a tech, and then I started as a brand new nurse in the CCU, which became the MICU, and then basically the critical care unit.
Yeah. So where'd you go to nursing school?
I went to nursing school at Mount Mercy.
Mount Mercy?
Yep.
Okay. Do they still have the 3-year program where you can get your RN after 3 years?
I'm not sure about that, but I actually have a biology degree from the University of Iowa. So I just did 2 years to get my BSN because I already had a biology degree. Yeah.
And you worked here as a tech while you're in nursing school?
Correct.
Okay.
Yep.
That's a common entry
common.
For people, which is great, and it's,
which I think was so helpful just because even just learning how the hospital works, it's, good to get your foot in the door before you start as a nurse or start as a provider, however it works, just getting the feel of how a hospital functions.
Yeah, definitely. Yeah. Certainly young people that want to go to medical school and, they need to build their resume. Back when I went, it was you took the MCAT and you had a grade point. Now, they have to kind of build. I said, be a tech on the floor for the summer.
It's so helpful.
Yeah, it will help you.
Even learning how to interact with patients. I think it actually started there.
And you kind of,
And you have the time and you don't have quite the pressure of what tasks are getting done.
And also you can find out, okay, this is not for me.
Yeah.
Before you get too far down the road.
Yep.
Why just choose cardiology? Because of your background on that?
Yeah, definitely. So I just kind of happened to get a cardiology job as a tech, and then I always really liked a specialty care, especially as a nurse working in the intensive care unit. I really loved critical care. So when I went to go do my schooling for nurse practitioner, that was at the University of Iowa, I elected to have most of my clinical rotations within a critical care unit, and I also opted to do the cardiomyopathy clinical rotation down there. So that's really where I got the exposure as what cardiology looks like from a nurse practitioner standpoint. And then when I went to go look for jobs, I knew I definitely wanted to stay within UnityPoint. That was always my goal. And the cardiology position was open, which worked out perfectly for me. I specifically focus on the heart failure patients within cardiology.
Yeah, that's what I ask. So, we just had a mutual patient here recently.
Yeah.
So do you spend time in the clinic and the hospital?
I
do.
Go
back and forth?
Correct.
Take us through that rotation. What's that look like?
Right. So my typical day is I start out inpatient, so that's seeing patients in the hospital here. I round on the heart failure patients that are needing a cardiology consult. That's not necessarily all the heart failure, but the ones that need a little extra attention. I round on them during the day in conjunction with the general cardiologist on, and then I go over to clinic in the afternoon, and I'm able to see the patients that I initially see in the hospital most likely,
for
and
follow-up.
I see them in the ambulatory setting.
Yeah.
So it's good because sometimes I do start my provider-patient relationship in the hospital, and I know where they've come from, and then I have a better appreciation of when I follow them in clinic.
And I've always felt like you also you feel a little bit more comfortable discharging them because you're going to be following up on it.
Absolutely.
You know, so you're kind of like, no, you can go home and I'll see you, in 2 days in clinic, as opposed to turning it over to another doctor. You're like, you don't want to leave too much for the other doctor to do because they're busy. It's in the middle of clinic, and the continuity is huge, and it's very rewarding, very satisfying.
Definitely helps with continuity. And then I'm able to, like you said, discharge them. I'm confident in the plan, and also I can continue to optimize them because, ideally when somebody leaves the hospital, you want them all teed up to do well. Right. But sometimes there are a lot of steps that you can take in the outpatient setting to continue to improve their cardiac health or their heart failure standpoint. So I'm able to continue that care and be confident that it's going to get done, that there's nothing lost in translation, and just keep close follow-up that those patients definitely require.
We could do a whole nother podcast on how, so I don't think a lot of particularly the cardiovascular medications should be started as an inpatient. You should let them get over with what they have, see them soon, can't be months from their discharge, then add on the medications as an outpatient. I think that's, I think sometimes you can put too much on someone at one time.
Yes, we definitely see that. And, eventually they will get to where they need to be from a medication optimization standpoint. Right. But we need to take the time and make sure that they're responding well and that we're adjusting to what the patient requires and selecting the appropriate medications, not just, using the recipe, but making sure it's tailored to what they need.
Right.
Yeah.
And, not a lot of chronic medications prescribed with someone that was laying in bed in your clinic for 2 days. You know what I mean? Right. So I don't know. I just think we can have you come back and we can discuss that some more. So your area of interest is congestive heart failure and the cardiomyopathy clinic. Mm-hmm. How much are you guys seeing? Are you still seeing cardiomyopathy related to COVID in the clinic?
We do see some.
I mean, we don't see very much on the inpatient side. I'm just wondering if you're getting
I have seen a couple just even admitted, but any time you can have basically from an infection standpoint, get cardiomyopathy. I was not in this position when COVID was, initially happening and at its peak, but I have seen just a couple of cases.
Whether it's related to the vaccine, I know there's some information out there about that, whether it's related to actually COVID illness. I can definitely say that cardiomyopathy from a virus, relatively rare. Mm-hmm. You had 1 or 2 a year. I'm talking where they get them into the hospital and they have ejection fractions that are super low, right? But you definitely saw that go up with COVID.
Yeah.
Whether, the virus, the vaccine, I don't know, but it definitely went up.
And I was a bedside nurse at that time in the ICU, seeing the ICU patients.
So you saw the
with COVID.
Sickest of the sick.
So I did see that even from a nursing standpoint, not as a provider standpoint. Yeah.
So we know what led you to UnityPoint, but what do you do after you're done at UnityPoint? You go home at night. What's some of the areas of interest?
Well, I'm a mom, so I hang out with my kids. I have a just turned 1-year-old daughter, and then I have a 3-year-old son. Oh gosh! So they keep me pretty busy.
I bet.
Hang out with the family and my husband, and I like to read, I guess. I used to like to watch TV, but that seems to...
Now you're just watching,
I don't really do that as much.
Bluey and Paw Patrol and stuff like that, right?
Like the Mario movie, which is a good one, but...
My kids, they're 23 and 20, so it was Monsters, Inc. and Shrek were like the two that we just watched over and over again. And I have to admit, the first Shrek's pretty funny. It was worth watching over and over again. And
otherwise, I like to do I like to go for bike rides. I did RAGBRAI a couple of times, not since I've had children. We like to go boating on the Mississippi up in Guttenberg. So there's some fun things that we like to do, but mainly hang out with the family.
A river rat at heart.
Yeah, a river rat at heart.
we each have our own. We know how we do what we do. We know what we do, but we all have a why. And I think one of the most rewarding things that a human being can experience is to find their why. Sometimes it might just be your family, right? But but from a medical standpoint, what's your why for taking care of patients?
I grew up, like I said, my mom was a nurse, but her father, so my grandpa, was a general surgeon up in Northeast Iowa. And then I also have some eye doctors, there's nurses, there's pharmacists. So you know how families tend to have kind of what is the common occupation? Yeah. Mine's definitely related to medicine. So I feel like growing up, I always just heard these stories about how impactful a medical provider can be with a patient. And my mom, being a cardiac rehab nurse, she always had these great relationships with patients, and it can be that she would take care of them for months at a time, and she would see great improvement. So I think just knowing that you can build a relationship with somebody and really have that impact on their life. I heard about it growing up. I loved hearing those stories. And I've always just been kind of a people person. I love working with people. I'm pretty social. So I definitely needed a career where I wasn't just, sitting at home, but I needed that human interaction. I also talked about how I just have a love for science when I initially got my biology degree. So it kind of all just accumulated into helping people, loving medicine, loving science, and nursing just seemed like such a good fit. So
that's awesome.
Yeah,
that's really cool.
Yeah.
What would you want patients to know about you? I mean, I think you've kind of led on with your last answer. But when they come to the clinic, what if you could tell patients one thing about you and the experience? What would you tell them?
First of all, I want to feel very approachable and available to my patients, especially these heart failure patients. I'm going to be taking care of them for many, many months, years to come. So I need to have just a good relationship with them. I want them to know that, like I said, I'm available to them, but also my discussions with them is a collaborative discussion with the patient. Yes, I, have this training and I have the medical knowledge, but ultimately that needs to translate into being successful in real life, especially with patients with chronic disease. And so how are we going to make that work? How can I meet you where you're at? How can I give you the information and the empowerment to, buy into what I'm telling you is going to help you from a medical standpoint? I just want them to know that I'm available. I'm here to listen. I'm here to work with them, and that my care is going to be an adjunct with anything that they have concerns about, or what their goals are ultimately.
That's a good philosophy. I've always believed there's two types of patients. There's ones that want a fraternal relationship, kind of, and make decisions together.
Yeah.
And there's others who want a paternal relationship, particularly like the old farmers, like, just tell my wife. No, we got a shot there. Just tell my wife.
Right.
Doc, I trust you. Just tell Alice. They don't. They're like, whatever. Just tell her. Which that's, as I get older, I kind of empathize more and more with them. But
there's always a little bit when somebody comes to see me, they've obviously had a failure of health at some point.
Right.
So there's gonna be some hard conversations, and sometimes I do have to say this is what's best, but I'm telling you that, and you have to decide if you're gonna cross that with me.
Yeah. I've heard some other doctors compare it to being a waiter in the restaurant. I'm going to present the menu to you. I'm going to tell you what the special is. I'm going to tell what's really good. I'm going to tell you kind of maybe what to avoid. Right. But ultimately, you make the decision.
Yeah.
And I think that's a good analogy.
Yeah.
I think because it does describe what we do. Because not every patient, you have a biology degree. The immense uncertainty of biology is it is not cookbook. Right. And you hear that cookbook medicine. No, there's no such thing because everyone is different.
Definitely.
Yeah. Well, Michele, this is really good having you.
Thank you.
It's nice to sit down. I'm glad I didn't put two and two together with your mom.
Yeah.
Who's, been a fixture here. Once again, this was Michele Tangeman, a nurse practitioner at St. Luke's Heart Care Clinic. If you're interested in scheduling an appointment with Michele, call St. Luke's Heart Care Clinic at 319-364-7101, 319-364-7101. Thank you for listening to LiveWell Talk On. If you enjoyed this episode, don't forget to subscribe, and if you want to spread the word, please give us a 5-star review and tell your family, friends, neighbors, strangers about our podcast. We're available on Apple Podcasts, Spotify, Pandora, or wherever you get your podcast. Until next time, be well.